I think AI is going to take over that. We were using the paid for ChatGPT over the weekend when I was on shift, and we were taking pictures of X-rays. We were telling it to read the X-rays, and it was like just as good as a radiologist. I know they don't want to hear that, but yeah, it's pretty good. We were wanting to do it with derm stuff we got to convince the patients, like, hey, can we take a picture of this? And then we wanted to see what the diagnosis it would give us, but we didn't make it that far. We didn't have any derm complaints, I guess. All right, so we're going to talk about secondary survey today. We talked about primary survey in the last class. So everybody remembers, obviously, we start with any gross major bleeding. We need to control that, and then we move into our airway, breathing, circulation, disability, and then obviously exposure, environment. We want to prevent any hypothermia. And during that, we have our adjuncts to our primary survey, like our chest X-ray, fast exam, and then if the patient demonstrates stability, we move into our secondary survey, which is what we're going to talk about today. So here's what the objectives of today are. Basically, an entire head-to-toe physical exam and identifying and treating anything we find along the way. All right, so the secondary survey starts once we have completed the primary survey and they've demonstrated hemodynamic stability, or they might not be hemodynamically stable, but they're demonstrating a response to whatever our resuscitation is that we're doing, whether that's blood products, which usually is what it is in a trauma patient. And so that basically says we don't need to take them straight to the OR right now. So we can move into our secondary survey, where we're going to do a complete head-to-toe exam on these patients, and systematic, obviously. And then we get any additional history, physical exam findings, and the mnemonic that the American College of Surgeons likes to use with the Advanced Trauma Life Support, which is the ample history. So we want to get, we want to know any allergies, like any current medications, past medical history, last meal, and then events leading up to what happened. So basically a little bit about the history. A lot of times this is important, especially during our secondary survey if we have time for this, because we want to know what happened, what caused, whether it was like a motor vehicle crash, they fell off a building, what happens if they passed out in that building up there, so they had a syncopal episode. So it's important for us to actually ascertain some of this history, or maybe they had a seizure while they were driving and it's the first time. So there's always considerations we need to look at when we're talking about events leading up to it. Maybe they were intoxicated, who knows? You'd be surprised at how many drunk people fall off ladders in San Antonio every day, quite a bit. But it's important we do a systematic, detailed physical exam identifying any other injuries that we have to treat acutely. So this might be, small lacerations we have to repair. We may be, I hate to, it's like one of the worst things is fishing glass out of people, but it's very common in a trauma center or any ER, trying to fish the glass out from a motor vehicle accident. It's always a pain in the butt because they're such small pieces, very difficult to get out. Do I want to do more damage, versus good when you're trying to remove those? Is it something we can leave in there? So it is a detailed exam, but we don't start it till we've demonstrated some sort of hemodynamic stability of the patients. Then we can move into our secondary exam. That's what we'll talk about today. What are some important things we want to know, for medication-wise, what they're taking? What are some important meds we want to know, especially? Anticoagulation. Are they anticoagulated? That's an important one. Are they on blood thinners? Because we're going to increase our bleeding risk. Obviously, we might increase risk of brain bleeds or bleeds anywhere. So that's always an important one we want to know, especially in a trauma patient. Are they on any blood thinners? And that'll be a common question that's asked. Something we see a lot is what the old people that fall down is actually, you think trauma is real sexy in the movies, or what's that new show? I haven't seen it, but The Pit, everybody says it's really good. And it's all that cool, sexy stuff, but half your day is old people who fell that are 80 years old, and they have a fractured hip and a head bleed. So that's actually what happens at trauma most of the day. And then maybe the cool stuff comes in every once in a while, but that's really what happens. So it's important we need to know if they're on blood thinners at that point, because we have to rule out some sort of brain bleed. If a pelvic fracture, that's obviously an increased risk of significant hemorrhage. but we'll talk about that today. So first thing we need to identify is what's the mechanism of injury, and most importantly, is this going to be blunt versus penetrating trauma versus both? And you can certainly have all of the above, which is very common, especially in a motor vehicle accident. It's also common with assaults. You'll have penetrating and blunt trauma, so it can be very complicated. But it's important to understand, what happened to the patient, and what makes it really difficult is a lot of times the patient is unconscious and they can't tell you what happened. So it makes it very difficult, which is why it's important we do that detailed head-to-toe assessment on them. But it is, penetrating injury can be easier to identify the wounds, but sometimes it can be complicated managing them. But blunt trauma gives you a kind of a tricky diagnostic situation because there can be so many things that go wrong, which we'll talk about here in the next slides. But obviously we want to address any life-threatening injuries first. And then all of this, basically our exam is going to be what determines the length of time they're spent in the ED. So are they going straight into the operating room? Maybe we found something along the way that needs to go to the operating room. And then are they stable enough to go to the CT scanner is probably one of the biggest questions we're going to have to answer so that we can figure out more of what's going on. And we'll talk about some of the CT scans we do and some of the differences, because I know it can be confusing to you guys because all we talk about, oh yeah, just get a CT, but there are a lot of different CTs. There's CT angios, there's CT with contrast, without, oral contrast, rectal contrast. There's all sorts of diagnostic dilemmas that these patients are going to place on us when we're working on them. All right, I'll give you guys a second to read this. Let's see if we remember what we talked about from the last block. What are we thinking? And don't be shy if you are thinking the wrong answer. That's how we're going to get you. That's how we get you to the right track, is by identifying those deficiencies we have and figuring this out. But this one, the correct answer is D. So what's in our primary survey? Yeah, I think I heard. Yeah, airway, breathing, obviously any major bleeding, airway, breathing, circulation, disability, exposure are going to be our primary survey, okay? So the abdominal exam is not completed during the primary survey. Our abdominal exam will be on the secondary survey, which is what we're going to talk about today, and some of our following lectures on the different types of trauma we can have. So we're going to start off with penetrating trauma first. So this is going to be typically a more focused exam if we can identify the actual wounds that they have, whether it's GSW to the leg or a blast injury somewhere, or GSW to the chest. That makes it sometimes easier, but it's still going to be very difficult. A lot of times we may still get a complete pan scan them still. Like I've had a guy shot with an AK in the leg, and it was mid femur. And it was in his spine, up in the thoracic spine, sitting right next to it, which is not obviously what we expected, but when we did x-rays, we're like, we don't see a bullet in there. Maybe we need to expand this a little bit and pan CT this guy so we can identify those injuries. So we do have to think sometimes outside the box, but most of the time, obviously with the penetrating injury, that can help guide your physical exam. It's a little bit more focused, but the priorities, we got to identify all those wounds and decide, do they need urgent surgery at this moment or not. And so some of that's going to be based on, obviously, some of those long bone fractures might require immediate orthopedic surgery. And then really the biggest one we deal with, especially on the extremities, is some sort of vascular injury is going to be probably one of our most important and determining factors, whether they're going to have to go straight to the OR or not, or whether we need vascular surgery involved. And like it says in the bottom, all of the decision making is based on hemodynamic stability. And that doesn't mean we have their blood pressure 120 over 80 or it's even over 100. This could be they had a blood pressure that was sitting at 80 over 40, and now it's up to 95 over 50. So we're demonstrating, we're demonstrating a response to the initial therapy. So this may or may not be an indication where we go to the OR. We may say, okay, he's demonstrating a response. Let's continue treating him here in the ED. All right, so the neck. Oh man, what could go wrong in the neck? So for neck injuries, we have so many important structures located in there in such a tight, confined area we like to use something what we call hard signs, which you can see on there in that zone 2 injuries are going to be most commonly where we see these hard signs. And it's important we identify what these are, which is typically like some sort of pulsatile bleeding, expanding or pulsatile hematoma, any sort of airway compromise or massive hemoptysis. Any of those hard signs on there, we need to take them to the OR for an exploratory surgery, okay? So these are going to be like any patient, with any sort of penetrating wound to the neck. If you see like a pulsatile hematoma, if you see expanding hematomas, pulsatile bleeding, we need to get them promptly to the OR for an exploratory surgery so that we can stabilize that vessel and stop the bleeding. But we break it down into zones 1, 2, and 3. So your zone 1 is from the thoracic outlet to the cricoid cartilage, or really it's cricoid cartilage to the clavicles. And then your zone 2 is where this is the area that's most visible that we can typically identify any injuries to those major vessels. And that's going to be between your cricoid and the angle of the mandible. And then zone 3 is the angle of the mandible at the base of the skull, which zone 1 and 3 we typically need further imaging, or if they're unstable, then we take them to the OR. But typically those ones are a little bit harder to diagnose by our physical exam. A lot of that's going to be history and patient stability for those. But for these patients, any sort of hard signs, they need to go straight to the OR for an exploratory surgery. And then anybody who, if they have an injury there and they don't have hard signs, then we need to look at a CT angiogram for those patients, okay? And then whether it's zone 1 or 3, then we have to decide whether we need a CT angio versus CT head. Typically, most of our protocols will get a CT head and a CT angiogram of the head and neck on all of those patients. And if it's any sort of involvement in zone 1, then we'll typically do a chest, abdomen, and pelvis as well. All right, so thoracic injuries, typically these are easier to treat in the trauma room. And these typically, if it's isolated thoracic injury, typically, unless it involves pericardium, we typically aren't going to take them straight to the operating room. So some of our, we tend to give a chest tube. It's a clinical diagnosis. So when we do the tube thoracostomy, or if we're doing needle chest decompression, if we suspect any sort of like tension physiology, we don't need a chest x-ray to diagnose that. That's based on our physical exam. So if it's unstable and we have that thoracic injury or any penetrating chest trauma, then we need to get a chest tube in them, followed by our chest x-ray. The point-of-care ultrasound works really well as a fast and reliable, rapid method that we can use to help diagnose any injuries to the pericardium. So we throw that probe on there looking for any sort of free fluid, and that can help kind of guide our management on these patients and decide whether, okay, they just need a chest tube, or they're going to need some sort of further management, whether like a temporizing measure, which we'll talk about in a sec, like a pericardiocentesis versus like a pericardial window in operating room or sternotomy. So our ultrasound is going to be a great test that we can rapidly use at the bedside. Any sort of penetrating injuries below the nipples, we need to suspect some sort of abdominal injury as well. So we also need to make sure we're evaluating their abdomen, and if they're stable, likely getting CT of that chest, abdomen, and pelvis on them. Then we also have to think about spinal cord injuries, neurogenic shocks. You can have that autonomic dysreflexia. All right. So like I said, if it's bleeding outside the pericardium, we stabilize them with a chest tube, and typically they don't go to the OR, depending on how, as long as we don't get any of those indications for an urgent thoracotomy. So as long as, we get a few hundred milliliters out of that chest tube initially, and the patient's demonstrating stability, a lot of times we can just transfer them either to the ICU or one of the step down or wards in the hospital for further management and just serial chest x-rays and examinations and monitoring chest tube output. Anybody who has over 1,500 milliliters initially on their chest tube output, if they have persistent, sorry, I meant to play that. It's just 200 milliliters an hour, so any output greater than 200 milliliters an hour is typically going to get a thoracotomy. And then, like, if they have persistent large hemothoraxes, or then with drainage and 2 chest tubes, then we'll a lot of times do it. And then anything involving tracheobronchial or esophageal injury, any major injuries, we're going to do an urgent thoracotomy on that. So it's important we understand our indications for urgent thoracotomy. So when a patient loses vital signs just prior to arrival, we have guidelines that we're going to talk about in the chest trauma lecture that we go by for different indications. So we look at what the time frame was when they lost vital signs, did EMS have vital signs at all during their transportation, and what did that time frame look like, and those will be some other indications that we'll talk about in the following lectures for this. All right, the belly. So, like we talked about in our primary survey, any unstable patients are going to go straight to the OR for an exploratory laparotomy. It's the stable patients that we have to do a significant exam, further evaluation exam, typically with a CT. We sometimes will have a chest and a pelvic x-ray as well prior to CT to help kind of identify. As you can see in the picture there where those bullet fragments go, it can be a very difficult decision, especially in the trauma room, on whether we need to go straight to the OR or not. So sometimes the safest bet is taking them there for a laparotomy for evaluating those penetrating wounds and making sure they haven't violated the fascia or the peritoneum. So, and we'll talk about in the abdominal trauma lecture on the stab wounds and bedside exploration on those patients. Sometimes we have to dissect down to the anterior fascia and verify that knife has not violated it, and then sometimes we can avoid taking it in the operating room. But that patient has to demonstrate stability for that to happen. But as you can see in the picture here, this guy has more of a superficial fragment. Looks like it's just in the muscle and it hasn't violated the peritoneum. And you can see the initial x-ray, and then you have the CT with that fragment there showing where it's located. It looks like he was a little fluffy, so he had some protection there that kind of helped him out. I guess maybe that's a good time to be overweight. I don't know. It's debatable. All right, so the retroperitoneum. This is like the bane of our existence because, like I said, unstable goes to the OR, but it can be very difficult with these patients because and there's all sorts of literature on how much blood you can lose there. Everything says, some says 4 liters of blood. I feel like if you lose 4 liters of blood, you're probably not alive, but some people, young, healthy people might survive that. But these are going to be patients that are a little bit more difficult to diagnose for those retroperitoneal injuries, just because we have so many vital structures back there. So stable patients, these are the ones we have to do a rectal exam on. If we have any gross, blood on rectal exam, great. A lot of times we don't, but we also have to rule out some sort of bladder or kidney injury when we're evaluating the pelvis and retroperitoneal spaces. They can also have colonic injuries. So, these are very complicated patients that we have to look at possibly CT scanning them. If you have any blood at the urethral meatus, you may have to do a retrograde urethrogram prior to any sort of procedures on them, because you can't get a Foley catheter in there, which we'll talk about coming up in a minute. But these are going to be people, they do have newer like CT tractography that you can help get contrast into the tract that penetrating wound took, and that can help us identify where it's going. It's still not it's still underutilized and doesn't have the best evidence, but those are other options we can use. All right, and then the extremities. So obviously we want to stop any bleeding that is compressible with some sort of tourniquet versus whatever kind of pressure dressing we can place, versus whether it's some sort of impregnated gauze if it's a non-compressible area. We don't recommend blind clamping anymore, which used to be a thing. We blind clamped the femoral artery or one of the arteries in the lower extremity to help stop that bleeding. But we found we damage a lot of other structures in the process, especially the nerves. If you guys remember, nerve, artery, vein, lymphatics, they all run together to enable mnemonic. They all run right next to each other, so there's a very high probability of injury in other structures. So we stopped doing blind clamping, or we don't recommend it anymore. Now, if we can identify that artery, then certainly we will ligate it or clamp it off to stop that bleeding prior to then going to the OR. But any of these patients, typically are going to require further management because we got to get orthopedics on board with these patients because they're likely going to require some sort of hardware. Most of these injuries require a vascular surgeon as well when you have this penetrating trauma to the extremities. So once again, this is when it's important that we look at our hard signs for any sort of arterial injury on the extremities as well. And if we suspect any of these, they need to go straight to the operating room so they can get an exploratory surgery, okay? All right, and then fasciotomy. So we always have to worry about compartment syndrome. Does everybody remember our 6 Ps are pain, poikilothermia, paresthesia paralysis, pulse deficit, pallor. So these are the, any patients we suspect that we have these, increased compartment pressures, we need to consider a fasciotomy. However, it's a very significant wound, as you can see in the picture when they're going to have very large scarring, and they're going to have a long recovery after these. So it's not a benign procedure, but anytime, indications, anytime we have any arterial and venous injury, so we're occluding we have some sort of disruption of flow to that entire extremity, which is typically going to cause an ischemic extremity. Any massive soft tissue damage is likely going to cause that compartment syndrome. If we have any delay in repair, and sometimes this can be they went to the operating room, but they also had a lower extremity fracture that needs to be repaired as well, and now they're in the operating room, it's taking longer, and now they have compartment syndrome, so it's something we need to always consider. And then any prolonged hypertension, excessive swelling, or high tissue pressure, they teach that they have those Stryker needles. I've still never seen a Stryker needle to measure compartment pressures. Typically it's, typically a physical exam and consulting with ortho or whoever the orthopedic surgeon is and deciding whether we're going to do this procedure or not. They do train emergency medicine providers to do fasciotomies. I hope I never have to do one. And then there's always those random other injuries, like, rarely a snake bite can cause compartment syndrome. So it's something we always want to monitor when we're evaluating those patients too. All right. Give you guys a second to read this. I feel like it's a repeat question, so hopefully you all know the answer. What do we think? D, right? Fat embolism. What if pulmonary embolism was on there as well? It'd be like a trick question, to credit at that point. But yeah, pulmonary embolism or fat embolism are going to be our biggest concerns. And and obviously this patient is at higher risk for both those because he has obviously multiple long bone fractures, bilateral femur fractures, but he's also a surgical patient as well, so you always have to consider pulmonary embolism on your differential diagnosis as well. All right, we're gonna do a quick overview of some blunt trauma. So this is probably one of the most common things we see is a blunt trauma, and like it says, fall from standing, fall from a height, off a roof, a ladder, anything, jump out a window. Some people just jump off, multiple story buildings after they're intoxicated, because somebody bet them. So motor vehicle crashes and assaults are probably our most common ones we're going to see in the trauma room. So we always have to worry about, especially with a fall, do we suspect any sort of closed head injury or TBI? Is there a brain bleed? Do we have good C-spine control? Can we clear the C-spine? And then what sort of other blunt mechanisms do they have? If it was a fall, then you're probably monitoring everything depending on the height. And we have guidelines that says like, well, if they fell from like more than 6 feet, more than their body height, more than twice their body height, but really it's all going to be based on your physical exam and your primary survey of the patient on what sort of concomitant injuries you think they have. What do you guys think's wrong with this guy? And he obviously took something to the flank area, so probably some sort of multiple rib fractures. Maybe some of the solid organ perforation or damage. I mean, is that just ecchymosis from bruising? from the trauma that he sustained, or is that like flank ecchymosis from something inside of him bleeding? So those are all considerations, which is why typically very low threshold, all these patients usually get CT scans, chest, abdomen, pelvis, and head. All right, so initial screening, obviously if they arrive in shock, then they're unstable, and we need to stabilize them first, or they need to go immediately to the OR if we have an indication that we think it's some sort of injury to the abdomen and pelvis. So obviously we do our initial screening test and our A, B, C, D, E, and if it's normal, then we can move on and look at some of these initial screening tests, which are gonna be like a thorough exam of their chest, abdomen, and pelvis, probably followed by CT as well, and that's with contrast. All right, so our most reliable screening method for any sort of blunt trauma in the chest is gonna be our chest x-ray. Adjuncts to that we might be able to get a little bit faster are gonna be our point-of-care ultrasound, our EFAST exam. And anything we identify, we need to drain those. There are some guidelines on whether it's 20% pneumothorax and there's no signs of tension physiology, then we might look at possibly not doing a chest tube, but most of them are going to get a chest tube at this point, especially if we identify anything on the chest x-ray that is greater than usually, some say 10 to 20% as well. And if they're unstable, then they're definitely getting a tube thoracostomy. They do have some, I don't even think they're newer, they have autotransfuser canisters. Some, I've seen these where basically you have your Pleurovac, which is all the blood drain, where all the blood drains out of the chest tube, and it monitors, and it hooks up to like intermittent suction on your wall. So they have newer ones that have autotransfusers in them. Typically, I guess if that's worst case scenario, you don't have blood, that might be a reasonable option to autotransfuse it back into the patient, but typically we're gonna give them fresh whole blood or some sort of balance therapy, or component therapy for bleeding. Like I said earlier, most of the time if it's isolated to the chest and there's no pericardial or cardiac injury, we can a lot of times manage them without taking them to the operating room. All right, and this is where the diagnostic dilemma comes in, is the belly. So there's so many structures in there and so many things that go wrong with blunt trauma. Almost every one of these is getting, that's stable, is gonna get a CT of the abdomen and pelvis, just for further identification. Like it says on there, the peritoneal cavity can sequester 3 liters of blood. The pelvis can, some say 4 liters of blood, and that includes the retroperitoneum, usually for that bleeding. But what can sometimes make these patients difficult is if they have any sort of head injury, they have distracting injuries, like let's say a fracture, or if they have, if they're intoxicated as well, that can sometimes overshadow your abdominal exam, and it can sometimes confuse you, and you don't think about some sort of abdominal trauma, which is typically why we pan scan these patients. But our exam is still important, and then we need to throw that ultrasound probe on there and get a fast exam. So, all right, and everybody see the picture there with the positive findings, and you have blood in there. And like in the notes, it talked about like old school they would do. You guys do know what a diagnostic peritoneal lavage is, where they basically place a catheter in the belly. They like put a bag below the level of the heart, and blood drains back into it, and they consider that positive. That's what they used to do before the fast exam. And they still, they still have done it throughout, like the GWAT, I've seen them do it as well, on those patients that they didn't want to take to the operating room, or if they didn't have another operating room suite, because a lot of times we're operating those on like an FST or something like that. All right, the pelvis. This is always a difficult one, just because of the amount of blood loss you can have within the pelvis. So, like we did during our trauma scenarios, obviously we need to make sure we're doing a good pelvic exam and we're compressing the pelvis. And it's not, we're not putting all our weight down on it. We're not rocking it back and forth. That used to be a thing. We rock the pelvis to see if we feel any crapitus or instability. Typically, it's just one press against the pelvis, checking for any sort sort of crepitus or any other signs that there's some sort of bony instability. And for those of you who are, if you're in a trauma center or if there's a trauma that comes in, typically the first time you feel one, you'll remember for the rest of your life. So once again, our FAST exam can be helpful here, but sometimes it takes quite a bit of blood to have a positive FAST. You have to think they're going to be supine, so that blood might be pooling down there in the retroperitoneum or the pelvis, and you might not have a positive finding. So we don't 100% rely on the FAST. We need to base it on the patient's stability, on their hemodynamic stability, and whether we need to take them to the OR to find wherever that bleed is. And then, everybody familiar with pelvic binder, like we have on the slide there? I know we had some during our scenarios as well, so that's obviously an important adjunct. What can you guys use if you don't have a pelvic binder? Yeah, basically anything that's going to put some sort of compression around there. Typically a sheet, if we have a bed sheet, that's a very common one we use if we run out of pelvic binders or don't have any. So sometimes you have to think outside the box, especially if you're in those roll ones, which a lot of you are going to be your first assignments at. So something to think about if you guys run out of these pelvic binders. All right, and then traumatic brain injuries. This is very common, and like it says, it's 20% of lung trauma patients who arrive in shock have a significant TBI. But typically with a TBI, and when we're basing it on hemodynamic stability, typically if you're hypotensive and it's caused by a traumatic brain injury, that's usually a very late sign that you're herniating. So typically if we have a patient who presents in shock and a TBI, we need to figure out where they're bleeding from, and we don't want to assume that that's due to that traumatic brain injury or it's a neurogenic shock. We want to make sure we fully evaluate them and determine whether that bleeding is actually coming from the belly and we just don't see it. So if we can get a neurologic exam, it's very important in these patients. Sometimes you'll only be able to get one from EMS because the patient had deteriorated along the way, especially if it's a significant TBI. So it's important to know what the GCS was on scene, and then it can help you trend where they're going. And like the slide says, and like we talked about, GCS 8 intubate. So any score lower than 9, we need to think about taking their airway. And then we also need to think about how significant that TBI is if their GCS is that low, so they might need an emergency craniotomy or some sort of burr hole or decompression of wherever that injury is. And we prefer to get CT in these patients if we can, but sometimes they're not stable enough to go to the CT scanner. So these would be cases we have to call. We have to do, we'll have to be doing multiple surgeries at the same time. So the surgeons will be in the belly, and then you'll have your neurosurgeons working on the brain at the same time. So it's always something we need to consider. But we don't want to chalk up that instability to a TBI until we've ruled everything out. And then another important consideration, especially for these head trauma patients, the scalp bleeds like crazy. So I've definitely had many scalp bleeds that are squirting blood across the room. So sometimes during our primary, even during our primary survey, if we have enough people, we'll have somebody throwing, remember that figure 8 suture that we talked about, they'll throw a figure 8 suture, or they'll ligate that vessel immediately, just because of the amount of blood you can lose from a scalp laceration. It's pretty significant. All right, so anybody we suspect of the head injury, if they're stable, we need to get them to the CT scanner. So that's a non-con head CT. With that, if the amount of trauma is significant enough, typically we add a CT angiogram as well of the head, brain, and neck. So looking at all those other vital vasculature that we have there, and identifying if there's any sort of injuries along the way. And like I said on the last slide, closed head trauma rarely causes hypotension unless they're herniating. Then we need to really think about where the bleeding is coming from. Do we need to get in the belly? And then do we need to get the neurosurgeon on board so we can decompress that hemorrhage that's likely happening in the cranium? And there are a lot of different, we'll talk about it during our TBI lecture. I think it's our last lecture, second to last lecture. So we'll talk about the different types of monitoring we can place in them to monitor intracranial pressure. Obviously, our exam and calculated and based off MAP scores and other things aren't as accurate. So typically, with this type of head trauma, even if we don't need to do any sort of neurosurgery, a lot of times we will place some sort of intracranial monitor in them so that when they're on the ICU, we can evaluate for any sort of injury there or any increase in ICP. And then here's our different common brain leads that we might see. So these are ones that typically you'll see a lot of these on board tests, on board questions. So we have our epidural hemorrhage, which typically is that lens-shaped hemorrhage that you see on the left there. And that typically involves the middle meningeal artery. Those are like buzzwords everybody needs to always remember with it. And the epidural is the one that has that lucid interval as well. So a lot of times, not a lot, but some of the times these patients will be walking on the scene, they'll be talking. However, they deteriorate along, sometime between the injury and the hospital, whether they're coming by EMS or not, or they'll deteriorate while you're examining them. So that's another classic finding you'll see with that epidural hemorrhage. And then subdural's that crescent shaped, and that's typically involving the bridging veins. So those are ones you guys, tearing the bridging veins on that one. Those are like buzzwords to keep together. And then you have your subarachnoid hemorrhage, which is your thunderclap headache. And that's typically some sort of cerebral arteries involved. They might have an aneurysm or rupture of an aneurysm. Sometimes we find these incidentally as well in patients that we're monitoring, and they'll have that aneurysm, and it's like a congenital issue that they might have been born with and had no issues with their entire life. And a lot of times we'll identify that if we end up getting CT angio on them for something else, and they may be asymptomatic. So it's something to think about. Then you have your parenchymal hemorrhage, which is usually the result of some sort of brain contusion, which we don't have a picture on now. All right, and then we need to consider cerebral vascular injuries. So we think they were underdiagnosed for a while just because we have a lot better testing now with CT angiograms, and we have a lot higher suspicion. So these blunt trauma patients, you commonly see this when they have a shoulder seatbelt on. So anybody you suspect, if they have any sort of seatbelt sign on the neck, this is something we're getting on every patient, a CT angiogram, so we can rule out any sort of cerebral vascular injuries. Once we started using that a lot more, then we started diagnosing them a lot more. So it's probably more common than we initially thought it was. However, most of them are symptomatic. So any sort of focal neurologic deficit, we need to consider this. We need to look at doing CT angiogram to have an impact with this. And then here's just some CT scan. This is CT angio showing where the disruption is or where the injury is of that vessel. Just from, I don't remember what mechanism this guy was, but this is why typically anybody I have a suspicion or I see a seatbelt sign on the neck, we typically get a CT angiogram on that to rule this out. And then does everybody understand the difference between CT angio versus just with contrast on there? So we basically they're all phase timed for the CT angiograms. And the CT just with IV contrast like the belly as well. So for like a CT angiogram of the chest for pulmonary embolism, we're looking at the pulmonary arteries. So basically they time the study so that contrast lights up the areas we want it to. And that's all a CT angiogram means. CT with a contrast, but it's looking at the vasculature that we're trying to rule out that injury to. So like if we're looking at an aortic dissection, we need to time it so that that contrast is in the aorta when the CT scan is attaining its images. And then obviously with CT abdomen and pelvis with contrast, we're looking mostly at like systemic and portal venous capillary beds. All right. And then obviously we love criteria. You guys don't need to memorize the criteria, but you need to remember some of those findings like I was talking about, whether they have a seatbelt sign or whether we see any of those hard signs like any expanding hematoma or any arterial bleeding. We need to consider like a cerebral vascular injury, and they'll likely need to get an exploratory surgery for that. right, so there are other secondary chest injuries other than just like a hemothorax, pneumothorax, so we need to consider rib fractures. They can be very painful, especially in elderly patients. So most places we require ICU management for rib fractures and pulmonary contusions, but we can also have blunt cardiac injuries, and those typically involve the right ventricle because it's the most anterior aspect of the heart, closest to the sternum, and that's where it's suffering that trauma. Then we always got to consider blunt aortic injuries. Supposing they made it to the hospital, a lot of those patients die on the scene when they have that massive aortic injuries and they bleed out before we can even, typically before EMS even arrives. All right. You've got a second to read this one. What do we think? Yeah, see, some sort of blunt cardiac injury. Let's say the patient's stable at this point. What are we going to do? Like, what would be like some of our initial? What's my initial imaging study I would do for this? Initial. Something we can do at the bedside. A fast exam, yeah, would probably be the initial imaging study we would use. Chest X-ray is a great, another great study that we would do during our primary survey for this. What are some other ancillary studies if I saw a run of SVT that I'd want to get on this patient? EKG? Yeah, EKG as well, okay. So if you see this in a stable patient, you've already gotten a fast exam, chest X-ray, you want to get an EKG on them as well, and you also want to look at troponins too, just looking for any sort of myocardial damage. All right, rib fracture. So very common. Obviously, any sort of trauma. I mean, I see it even in simple falls. I saw somebody who got rammed by a goat recently, had a couple rib fractures. So, this is something we always need to consider with any sort of chest trauma, not just whether they have a pneumothorax or any sort of underlying injuries to the liver and spleen. We have to think about those rib fractures. And then we got to think about what location they're in as well, because sometimes like a first rib fracture takes a lot of energy for that bone to break. So we need to consider whether there's any associated blunt cardiac injury with it, so we have to rule that out. And then we have to think about a flail chest as well. So that's going to be, 2 fractures per rib and 2 or more ribs. And it creates that free segment and paradoxical respiration. And these patients can sometimes be tricky to manage because we don't do a lot for them. They can, they can place hardware in there to help stabilize that area. But most of these patients are going to have a pretty significant pulmonary contusion, and they'll have a severe pain. So all these, flail chests are all going to get managed in, on the ICU with respiratory monitoring. We give them significant pain control. Sometimes we'll do an epidural block as well, and anesthesia will come in, and we'll give them a block to that whole area to help with the pain. All right, and then pneumothorax. Like I said earlier, if there obviously any tension physiology, we need to immediately do a tube thoracostomy, or in the interim temporizing measure, we can do a needle thoracostomy. But the tricky patients are the ones that don't have any tension physiology, and then we like to look at what size and how large that pneumothorax is. And sometimes those are what we call occult pneumothoraxes, or small ones. We may only see it on the CT scan. We might not even see it on the chest X-ray. They can be so small. So we have to make a decision on whether that's somebody who needs a chest tube versus just serial exams, admission to the hospital, oxygen, and we monitor them until they're recovered. All right. we thinking? Yeah, A on this one, why? Yeah, the patient's stable, right? So let's say she, I mean, if it was a 10%, but she's unstable, then what would be our treatment? Yeah, based on the scenario, likely a chest tube. Obviously, in real life, it's a lot more complicated, but the question is, why is she unstable if it's only 10%? I don't see tension physiology. Is this patient bleeding from somewhere else that we haven't identified? Maybe we didn't see it on the CT of the abdomen and pelvis. So those are always considerations, especially like retroperitoneal structures can sometimes be injured and have bleeding, but we don't see anything on the CT scan. So sometimes we'll look at whether there's any extravasation of contrast or other findings like fat stranding, sometimes air, any free air in there, so they can be subtle findings. That may be another indication, but yeah, based on just the scenario, if they're unstable, likely a chest tube. However, it's probably bleeding from, she's probably bleeding from somewhere else. We need to do a further workup, or they need to go straight to the OR. All right, let's take a 10-minute break. Be back at, let's say, so we're gonna talk about tamponade now. So anybody that has any signs of like any Beck's triad or any sign of like tamponade with like persistent signs of like distended neck veins, tachycardia, these patients are going to get an ultrasound in the ED, so we're going to do that ultrasound of the heart looking for any fluid. As you can see in that top image, you see that free fluid there that in the pericardium that shouldn't be there, and then you have a collapse of the right ventricle, so the heart's not pumping appropriately. And so that's indicative of tamponade physiology. So we, typically by the bedside we can do that ultrasound for these patients. However, any signs of like Beck's triad, do you ever remember what's in Beck's triad? Yeah, so they're unstable at that point. So they have hypotension, muffled heart sound, JVD. We need to consider that they might have a tamponade, and we need to get them to the operating room immediately. So some of the things we can do in the meantime, like a temporizing measure, is a pericardiocentesis. Does everybody know what that is? It's like a big needle stuck at subxiphoid into the heart. So you run some risks, obviously, with that procedure when you're sticking, a 12-inch needle into a patient, or it might even be longer than 12 inches. I can't remember the exact size, but it's also not going to fix the problem. It's just going to drain a little bit of fluid out of there, and they're probably still going to have some bleeding. So they need to get to the operating room. And some of the things we can do for this is like a sternotomy. Everybody know what that is. We cut the sternum. So basically we have to cut the entire bone of the sternum. If you've ever seen somebody with a scar, it's gigantic. And they typically wire them shut when they're done. So they'll have some sort of wire hardware. So if you ever see a chest x-ray with that, you'll know, oh, that guy had a sternotomy. I wonder what that was from. Now, a lot of times that can be from like a CABG procedure or other like heart procedures. But typically in the trauma room, and when we're working about a tamponade, that's typically what we're going to do is a sternotomy and then repair wherever that injury is. I think it was an Iraqi. He was like shot in the chest or something, but we ended up having to do a thoracotomy on him, and he had he had basically got a laceration of the pericardium from that bullet, but there was blood causing tamponade physiology in him. And the surgeon was like, hey, hand me a Foley catheter. And we got this guy's chest open. I'm like, oh, Foley catheter? And he stuck the Foley catheter in there, blew up the balloon, and we just withdraw the blood off till we get him to the OR. So these patients typically are in extremis, and they're going to need immediate or urgent surgery for them. So in other procedures they can do is like a subxiphoid pericardial window is another one that they might do as well while they're being transported to the OR or while they're in the OR. And then obviously if they deteriorate and lose pulses, then we typically do a resuscitative thoracotomy, which is what we did in that guy that was in Iraq that had that laceration of the pericardium. And then what's that EKG called that's on there? Yeah, electrical alternate, so it's alternating QRS complexes or amplitudes and all of the leads across your EKG. All right, so aortic injury. So this, we typically see these from a rapid deceleration injury. We used to see them a lot more commonly when all they have is lap belts and they smash into a steering wheel. This is why you should wear your shoulder belts. And you probably shouldn't ride motorcycles, no offense to motorcycle riders, but they're usually injured pretty significantly. But typically, for any of these blunt aortic injuries that we tend to see, the most common location is just distal to take off the left subclavian artery. And then we might see, multiple findings on chest X-ray can be indicative of this. So they have that loss of the aortic knob. We might see, like, if we have an NG tube, there might be some deviation. They might have an apical cap, or we might see widening of the mediastinum or other indicators that they could have an aortic injury, and we need to immediately get that repaired. Anybody that, obviously, we suspect this, and if they're stable, we're going to get a CT angiogram of that aorta. And then we also need to think about anti-impulse control, which I think we talked about before with other aortic injuries and dissections, but they need a beta blocker. And then we need to look at that imaging if they're stable enough and decide whether they need to go to the operating room and whether they can repair it immediately or whether they can wait or whether we can just monitor them. But these are usually pretty significant injuries with significant bleeding, and typically they don't make it to the hospital. But when they do, they require significant resources from our hospitals. Then we have diaphragm rupture. So this can, cause pretty significant respiratory distress, and typically it's from blunt trauma. Typically on the left side of the chest is where we're commonly going to see these. And then if there's any question about this, a lot of times if we consider it or we suspect it, we'll sometimes put a nasogastric tube in there. And a lot of times we'll see it curled up in the stomach, but we'll see that in the left side of the chest where there should be lung, and that's usually a good, an easy diagnostic tool we can use. We can also identify it on CT, but these patients are going to need to go to the OR to get that fixed. Sometimes we will confuse it for like some sort of, hemothorax or pulmonary confusion. That's why sometimes we have to place that NG tube in there to help us identify it emergently in the trauma room. And then we have our hollow viscous injuries, and these can be very difficult to diagnose, just because they might not have any outward signs of this on exam. So we have to consider with any sort of concerning mechanism of injury, which our next lecture, we're going to talk about radiology and our trauma imaging studies. This one we might see with those like chance fractures that we see in the spine, which we'll talk about tomorrow. So these are ones we have to be concerned for, like hollow viscous injuries in the retroperitoneum most commonly. We do have like methods to help us identify this. Like we can look at their amylase levels. However, it's non-specific, but with the right mechanism of injury and elevated amylase, we might consider that they have some sort of like pancreatic injury or a retroperitoneal injury. So that's why a lot of times we'll trend these patients serial physical exams, just because the CT scan is unreliable initially with them. If we may have findings that just show some free fluid, maybe some bowel wall thickening, some fat stranding. Those are like subtle indicators that they might have some sort of hollow viscous injury. And then, this is where our FAST exam comes in when we're looking for this like solid organ injury that has a significant bleed. And then if they're stable enough, obviously we would get a CT on them with IV contrast, and we might identify, typically most commonly it's going to be like a liver laceration or a splenic laceration are probably the two more common ones we're going to see when we CT scan these patients. But any patient that's unstable with positive FAST, we need to take to the OR. If not, then we get the CT scan with contrast. And there's, many different organs that can be injured. A lot of times now we don't take them all to the operating room like we used to. They used to, whack everybody's spleens out. They used to, remove portions of the liver, but now even like some of the more significant higher grade injuries of these, we can manage them non-operatively. And if that facility has interventional radiology, a lot of times they can do procedures and angioembolization to help in the more severe injuries or higher grade injuries that we might see with these solid organ injuries. All right, let's talk about renal trauma. So we always have to consider whether there's some sort of kidney injury with any sort of blunt trauma. And even in like kids, we see these handlebar injuries. Sometimes we'll get a handlebar injury, and it was important in these patients that we get a urinalysis and we're looking for any sort of hematuria. So we, with the right mechanism, we need to think about the kidneys. Most of the time, they're protected in the retroperitoneum by our rib cage, but depending on the mechanism, we have to consider this. And then once again, CT is going to help us identify this. And typically, these are managed non-op as well. We just monitor their Foley catheter until we have clear urine coming out of it. And then we may or may not do a follow-up CT depending on how significant that bleed was that we identified initially. And then GU trauma, so anybody with a pelvic fracture is something we need to consider, that they might have some sort of urethral injury, bladder injury. They could have, some sort of rectal injury as well. We need to have a high concern for this. For most of these patients, especially with pelvic fractures and unstable ones, they're going to go to the operating room. And so before we go to the operating room, we typically throw a Foley catheter in them. These are patients we need to be careful with, just because if there's a urethral injury, your Foley catheter, typically you're not going to be able to insert it. You're going to meet some sort of resistance. However, if you have a high concern like blood of the meatus, inability to pass the catheter, they're not able to void, we need to consider doing a retrograde urethrogram in them to diagnose any sort of injury there before we put that Foley catheter in. And then there are different procedures that the urologist can do, like a wire guiding catheter. They can do a suprapubic catheter. There are other options we have if we have some sort of damage to that urethra. So we need to consider this in all of our pelvic fractures. And then this is another good one for, like, even with our pelvic fractures, looking at the FAST exam, they might have some sort of bladder injury as well, so we need to consider that. It's a pretty easy one, right? Only we wrote them this easy. So yeah, Weidman-Gestein on this one. So those are the most common finding or likely finding we're going to see on a chest X-ray with these patients. All right. So one question I haven't heard is, if we go to the OR during our primary survey, have we identified all these other injuries? We haven't done a secondary assessment yet on these patients. So what do we do for those patients? Does everybody have an idea? So some of those patients will go to the OR immediately, and they might have concomitant other injuries, whether it's some sort of most commonly probably fractures are ones we see that we may not diagnose till after surgery. So what we do at that point is what we call a tertiary exam, which is not fun. And typically it's right after they come out of the OR, they'll go to the ICU. And then we'll do what we call a tertiary exam, and sometimes that's when we identify a lot of these additional injuries that we find on these patients. But sometimes we don't complete our entire secondary survey on patients prior to them going to the OR. So maybe they'll find it intraoperatively, but most likely it will end up on the ICU, and there will be somebody like me rounding on them and having to identify all of these other injuries and getting multiple X-rays, CT scans. But all right, so obviously we talked about blunt trauma, how complicated those can be to manage, and really we have to suspect everything, but based on our mechanism of injury, that's going to help us guide what we need to do for these patients, and whether we need to pan scan them, whether we can get away with just plain film imaging, whether it's simply just extremity injuries. These are all considerations we need to have with blunt trauma. So at the end of the day, this is what I care about in the ER, what's the disposition of this patient. So do we need to get them to the OR? Do we need to admit them to the hospital, or can they go home? And so we have lots of different options. Obviously ICUs reserved for our most critically ill patients. They require like one-to-one coverage. If we suspect any cardiac injury, we may have to send them to the telemetry floor that monitors their cardiac function the whole time. So they'll have, typically we have techs in a room that actually monitor telemetry 24/7 on patients that go to that floor versus a medical floor, which is supposed to be really, they get checked on twice a day at shift change, but it's supposed to be every 4 hours. So it's a lot, those are for a lot less acute patients. And then a lot of times we'll downgrade these patients in the emergency department once all our imaging comes back. We've sewn up any lacerations, we've splinted any fractures, and if nothing needs any sort of acute management or surgery, a lot of times we'll send these patients home. And then here's just a little bit about our different levels of care. So obviously, like I said, the highest level of care is our ICU. So if they're on a ventilator, they need to go to the ICU. If they require any sort of continuous medication drips, they'll go to the ICU. Obviously ECMO, you guys know what ECMO is. Yeah, so if they require any ECMO, they're going to go there. They do have constant telemetry on the ICU as well. And we do have to worry about, we actually see it on the ICU a lot, as alcohol withdrawals are a very common one too. And it's very common for trauma to go along with that. So a lot of the times we have to monitor a CWAS score once they're out of anesthesia and looking for any signs of alcohol withdrawal. I had a lady with she was like 80, but she had a brain bleed, but she was drinking like 3 fists of whiskey a day. So significant DTs. She had seizures before, and we were giving her like more Ativan than a normal human can tolerate, and we still weren't controlling her symptoms. And we actually had to prescribe her beer on the ICU, so she would drink beer a couple times a day to avoid DT and alcohol withdrawal. That's how severe it was. But for the ICU, they typically want vital signs every hour. You should have a 1-to-1 nurse ratio. And then you'll have multiple different specialties rounding on those patients every day when they're in the ICU. And then, like I said, our telemetry, constant cardiac monitoring, and then our medical floor, which is supposed to be the vital signs, every 4 hours. That typically doesn't happen just because of like personnel shortages. So I noticed they do a lot of shift changes, and you have to be, if you're worried about a patient on the medical floor, you need to go round on them yourselves. This is typically one nurse for like 6 to 8 patients. They're doing a picture of like a loop recorder implantation at the bedside on the telemetry floor. We actually have better or less invasive methods, I should say now. We still do loop recorders, but we have, have you guys ever seen like a Zio patch? It's like a little like oval shaped patch they can put on. It's like sticks up about 1 centimeter, and it's very small, and they can actually wear that, and they can have 24-hour telemetry on that as well. So that we have other options instead of doing an implantable loop recorder like we used to do on everybody. All right, so we talked about our secondary survey and physical exam, what we're doing for these patients. What questions you guys have?
Sir, what's the utility of a chest x-ray in like chest trauma patient? I know we said like chest x-ray is the best study for seeing if someone has hemothorax, but I guess I'm just trying to picture like what you could be seeing on a chest x-ray.
Yeah, so we can see if they don't have any tension physiology, sometimes we might might not notice on their physical exam or vital signs that they have significant, like a significant hemothorax or pneumothorax. That can help identify. Any significant rib fractures are going to be identified on there. Obviously, any sort of cardiac injury, or aortic injury, if we're worried about like some sort of traumatic aortic rupture, we might see that wide and mediastinum. But we do it because it's so quick. So usually during our primary survey, when we log roll the patient, we are typically getting a chest x-ray immediately. And it does give us a quick indication of any sort of physiology that could acutely kill that patient that we can treat easily with say a tube thoracostomy, or whether it looks like something we might need to do a thoracotomy with as well. So it is a good test. We obviously have a lot better ones now. Well, another reason we do it is a lot of patients aren't going to demonstrate hemodynamic stability enough to go to a CT scanner, and it's going to be very quick. We read it right there while the guy takes the picture, or gal, right on the machine right there, and it can give us a quick snapshot of what's going on in the chest. What other questions? Nothing. Alright, I'll hang around for a couple minutes in case anybody has